I really do want to thank you for the work that you're doing as well. I suppose I'm following two drugs in particular, and that's Translarna and Spinraza. And I suppose that's what brought me to the whole thing of the rare diseases. I'm not a permanent member of this committee. And what's been really shocking to me is the lack of transparency, and it was mentioned here several times. And we see when you don't have the transparency, you don't have the trust. And that's the real issue that we need to tackle. As I see it, there's two issues. There's the transparency as we are here, and also the delays and the blockages that are within the system. And then it's how quickly we can get to a European situation where we have the Benelux benefits, say, kicking in, that people are going to really benefit from that. So my first question probably is, are there specific things we can do to bring transparency to the process as it is at the moment?
Well, it kind of comes back to my previous point about what they do in Scotland and also what they do in the UK. I mean, I think the point was made earlier as to comparing the NCPE to what other jurisdictions use to assess. I think there's a great value in having that independent scientific assessment process that is
and because I have a limited time because they're outside the door as well. How long does it take to for approval in Scotland, on average?
In terms of the approval times, I wouldn't be privy to that information. All I know in terms of in Ireland, there was a recent analysis done by the NCPE in terms of the assessment process, which to everybody here is quite transparent. But in terms of maybe the reasons and the steps along that process where there was a stock clock or there was a gap, that's only recently been done through a manual process in the NCPE. We don't have the equivalent on the reimbursement side at all in Ireland, and as far as I'm aware, in Scotland, they don't have that kind of breakdown either, and that's certainly something we'd like to see more of in terms of when the clock stops, what's it due to?
That's exactly what I'm trying to get at. Yeah. Is it a blockage, a human blockage, or is it a lack of resources, or what is it?
I think that in terms of getting a real-time analysis of that, I think it's very difficult to get, because it's obviously it's a confidential negotiation. So you'd only get that information in retrospect once a negotiation has been completed.
Yeah, I think it's an obscure. Are you clear at all on the cost-benefit analysis that's used? How many negative or positive externalities are taken into account, or how the decision is come to? Is it long, short, medium term?
We certainly would argue they generally tend to look at one particular aspect of a disease and say, how does the drug impact on that? And kind of what we've been arguing and why there's need for a bigger review is that these new drugs are impacting in a much more holistic way, so that really the drug needs to be measured on 4 or 5 different endpoints, not just one. And quality of life, of course, is absolutely vital in terms of that, and that really has to be taken absolutely seriously. But I think at the end of the day, you can have all the processes in place, and the Scottish system is very good, but the point that you're making is, what are the outcomes and what are the results? And certainly we would remain suspicious if all these new processes are put in place and we still find that Ireland is the only country in Europe that doesn't approve a particular drug. Why is your suspicions are definitely aroused when it's available in most other European countries.
And that's the point. I suppose the European Medicines Agency, is it worth anything? Is it of any value at all? Surely if are their standards less than the standards we have here? Is the treatment, or these are often for children, is a child different in another country than it is here? Why don't we take the European Medicines Agency's decisions and say, okay, right, now we're here, what's the other part we need to get in order to get it approved in our own country? I can't understand why we keep reinventing.
I think just to clarify, I guess, the European Medicines Agency says whether a drug is safe.
That's right.
and effective.
Yeah.
Does it do what it says on the tin? They do nothing around pricing. They don't.
I understand that completely, but that's why. Yeah,
and the question is then, should we add that on to the EMA? Should it be the next stage of the EMA where Europe comes together?
Yeah.
And I think with the reference networks and stuff, it will slowly move in that direction. But in the intervening period, we need to do something to cover ourselves, I guess.
And you see, time is what we don't have, as you know, in a lot of these cases. I've had huge issues with the cost as well, because the cost isn't negotiated. So you're taking a headline cost and you're working out your cost-benefit analysis on that, but you can't hope to do that. When the drug company is given a cost expecting it to be negotiated, rightly so, would happen in any business negotiation, and it's not being negotiated by the HSE. I mean, how can you hope to have an outcome that would be positive in that situation?
I actually defend the HSE a wee bit, because actually, you know, even in terms of our own experience around where it can be, and they got a massive reduction in terms of what was offered originally. You know, I can't reveal the price, but also they brought this innovative system is where if there's better drugs come along in the future, we'll automatically get those, and that's now being copied by other countries. So there are occasions when they can get it right as well, you know, and we need to build on that good practice too.
It needs to be got right all the time, because it certainly was not done in Translarna.
Absolutely.
And 22 other countries.
I mean, you can see, I went to the annual conference of the Duchenne muscular dystrophy children, and you know, to see that they have a window of 2 or 3 years, and if they don't get the medications, you know, they'll go into a wheelchair straight away. They won't be able to walk, you know. So, you know, absolutely, you know, those medications are available broadly in the rest of Europe. It's hard to see why, other than the cost seems to be the factor of why they're not being brought.
The delays in the Benelux and the impact from there, we know with Spinraza that has been improved in all of the Benelux countries. Surely we can take that and use that as a lever here to give it, because again, with these children are being admitted to ICU, you have all of those costs as well as the distress of everything. So it even taking the whole inhumane thing out of it, just the additional costs and all that are building up by trying to.
I guess the question comes down to, are we willing to even pay the price that Benelux have negotiated? I don't know. I think just before we finish up, there is, in the very short term, I think the big thing that we as patients and patient organisations would like to see happening is a little bit of the opening up of what's this relationship between the pharma and the HSE. We have no visibility. Things go into what we term as the black box. I think opaque is a nice phrase to use, but with no visibility, and it could be a year, 2 years, 3 years. Now, in the intervening period, we're hearing anecdotally from industry, because industry are far more willing to discuss this with us than not, that they've had a meeting, or they haven't had a meeting, or a phone call we've had, or an email said. But the fact that there's no visibility around that, I think, is one of the biggest challenges that we face in the short term, and it would be an easy thing to address, I believe, to say at least there was a communication and this was what it was in broad terms, or they held a meeting and they've promised to come back in 3 months' time. You know, I think that would help us a lot in the short term, and then we'll look at rebuilding the systems and stuff like that.
The fact that the clinicians aren't involved in the decision making, you know, we're lucky in this country of this size that we have really well qualified clinicians, and their opinions are just dismissed. I mean, you would have to say that there is a protectionism within the system that isn't serving either the clinicians and certainly not the families and the people who need the solutions and need the treatment to the diseases.
And I would say there's a cynicism as well. I talked to pharmacoeconomics people from across Europe recently, and they all seem to have the sense that patient groups are somehow in the pocket of pharma companies. You know, like there's a cynicism there, and I mean it's really insulting, to be honest. You know, I think as patient groups we'd be betraying our patients if we ever advocated for a drug which wasn't effective. It would be disgusting. Am I right? So I think, you know, we need to maybe be more robust in showing that. But clinicians get accused of the same because they're involved in clinical trials and so on. I mean, it's so simplistic and so wrong, and I think it needs to be challenged, really, you know.
Thank you very
The
much,
Minister
Mr. Walsh.
needs to challenge it.
Thank you, Senator.
I'll leave it at that. Thank you.